So good evening. You can hear us, sir?
No,
So,
I can hear now. Yeah,
yeah.
Thank you.
Yeah. So you would like to check the slides first, or we'll just...
You can start whatever. Yeah.
Okay.
I'll share the slides after you finish.
Okay. Yeah. So, Sandeep, we'll start. Dr. Varsha?
Yes, ma'am.
Yes, ma'am. Yes.
Start.
Good evening.
Okay. Yeah. Yeah. You can hear. Am I audible?
Yes.
Yes. Okay. So, hello. A very pleasant Saturday evening to everyone. On behalf of the Department of Clinical Immunology and Rheumatology, Bharati Vidyapeeth Medical College and Hospital, I extend a very warm welcome to all of you for this academic session on Sjogren syndrome. Sjogren syndrome is one of the most puzzling enigmas of medicine. And though categorized as an autoimmune disease, its constellation of symptoms can be very diverse, from multiple dental caries, chronic dry eyes, hoarse voice, dyspareunia, gastrointestinal issues, renal calculi, and even hypokalemic periodic paralysis. And to unravel the mysteries of this challenging disease, we are deeply honored to have with us today Dr. Debashish Danda, Senior Professor and Founder of the Department of Clinical Immunology and Rheumatology, Christian Medical College, Vellore. Dr. Danda is DM Clinical Immunology and Rheumatology, FRCP London. He completed his advanced training in rheumatology at the Royal Adelaide Hospital and Queen Elizabeth Hospital, University of Adelaide, Australia. He is an International Fellow of American College of Rheumatology, Fellow of National Academy of Medical Sciences, India, Fellow of Indian College of Physicians. He has been the President of Asia Pacific League of Associations of Rheumatology, APLAR, Convener for APLAR Vasculitis Special Interest Group, and IROVAS, Indian Rheumatology Association Vasculitis Special Interest Group. He has been the immediate past chair, ILAR, International League Against Rheumatism. He has 273 publications to his credit. He has been the past editor-in-chief of International Journal of Rheumatic Diseases and the past president of Indian Rheumatology Association. A very hearty welcome to you, sir, and hand over the session to you for your talk.
Thank you, Dr. Kavita, for this generous words. I just share my slides now. Just give me a minute.
Yes, sir.
Dr. Kavita, is my slides visible?
Yes, sir. We can see your slides.
Good evening. The Department of Clinical Immunology of Bharati Vidyapeeth, Pune, and all the attendees and the faculty and I think my job will be much easier because Dr. Sandhya was in Pune a few days back, and she spoke on similar things, and she was my student, and I have sort of we still work together, although she moved out to Delhi, and you might find some things are common, what she presented, and a few slides may be common. So, but Sjogren syndrome is something where I learned it in a hard way, and I would like everyone to know that this is a victim of probably the whole of specialty of rheumatology is victim of misconceptions. I think no other specialty is a victim of misconcepts apart from psychiatry in medicine, as rheumatology is. And within rheumatology, Sjogren syndrome is one such misunderstood or missed out disease. So in this slide on my left, if you see the bullock cart standing there, that is where the CMC Vellore started. And whatever I'm presenting on the right side, this is the centenary building of CMC Vellore. Whatever I am talking today and whatever strengths I have gained is because of this institute. I mean, I have no hesitation in calling it the Mecca of medicine in India. So this is the lady, this is the lady on the left side, Dr. Ida Scudder, who was the daughter of a missionary who had come to Vellore to visit her parents. She was not basically a doctor. She just finished her graduation and she came to Vellore to see her parents. And there's two interesting stories that because those days, more than 150 years back probably, villagers brought two ladies in labor and thinking that, a young lady from with Western ancestry must be a doctor in the missionary family. So they wanted her to deliver. She could not deliver. She said, "This is not my job. I'm not a doctor." She refused. That lady died on the way of obstructed labor. And the same night, the first one was a Hindu lady, the second one was a Muslim lady, had a similar story, and she also died on the way. And the villagers surrounded them and told, "What kind of missionary you are? You can't even do this kind of thing for our people in our villages. We don't have any lady doctor." They wouldn't go for obstetrical problems to a men doctor. There are few men doctors around. So she took it up. She was not at all interested to become a doctor. I think she was probably close to 30 and she went to Boston back. She did her medicine and postgraduated in obstetrics and gynecology and came back to Vellore and started this roadside bullock cart clinic and a two-bedded maternity hospital, which is today's Vellore, CMC Vellore, which is one of the busiest, biggest and multi-speciality hospital and really a blessed place. So it's from Chennai, about 125 kilometers down south. So with this background, I wanted to say that the common perceptions of Sjogren syndrome is these three misconceptions or the myths are in everybody's mind. The first myth is it is essentially a dry eye, dry mouth disease, but the actual pearl is it is a multi-system disease. Dry eye and dry mouth is not, you will come to know as I speak, that it's not the most important thing in Sjogren syndrome. The second misconcept is the Sika symptoms are the presenting complaint in all patients. And this is another misconception. Majority of the patients do not volunteer of Sika symptoms. And third thing is it's rare in India. That's like many things we learned. We used to know at once during our student life, we don't have multiple sclerosis is rare in India, lupus is rare in India, so many things are rare in India. So it was considered as rare, which is not the truth. And above all, a very common mistake is to pronounce it as a Sjogren. It is correct pronunciation Sjogren. SJ in German is pronounced as SH. J is like H. And Sjogren syndrome's thesis was Sweden, and those days Sweden had official language German for education, higher education, and Sjogren disease thesis there. Now, why is it so? Because of the image in our mind of Sjogren syndrome is that of this. Completely dry tongue, the teeth are all, very bad, and big parotid gland. So this is actually the reason which stops us from thinking further. And the knowledge bias is because of the Western literature influencing our thinking. So the most of the literature came from Caucasian population, and the overall impression was therefore like this, as you see in the picture. And this is probably not the prototype, not only in Indian patient, and gradually we have been successful in creating awareness globally that Sjogren is not a disease like this. This is a very advanced disease. It's like most of you know that when we are MBBS students, we are giving a final year exam a hand with a deformed hand, with even a blind man can feel it and say it is rheumatoid arthritis, the sore neck and boutonniere deformity. Or an X-ray of a bamboo spine, which anybody can say it is ankylosing spondylitis. Similarly, I showed you the picture of big parotid gland and completely dry mouth and dry eye as Sjogren syndrome. Now, this is not the story. This is the story of a very advanced disease. If we wait for these things to happen, then we lose all the window of opportunity. So basically, I'll just give you a story which I have derived from a real life patient. So a 49-year-old female with 5-year history of recurrent attacks of severe proximal muscle weakness in presence of normal muscle enzymes and normal vitamin D level. And the patient visits Center of Medicine and Neurology. Excuse me. And this patient, then goes to further follows up with internal medicine and endocrinology because she has low potassium, and endocrinologists did a ABG showing low potassium, so low pH and low potassium. And by now it's very clear to you that there are very few acidotic conditions with hypokalemia. So she also has history of edentulousness from the age of 35, which is unusual, and she has a dental consult for it. And she has pain in the joints of small joints with minimal contractures, which responds to NSAIDs, and she also, which is the correctable deformities, and she has features of asymmetric peripheral neuropathy. So she again comes back to rheumatology and neurology, and she gives history of fetal loss, late fetal and early neonatal complications, and history of dyspareunia, and the obstetrician and gynecologist is having no clue about it. And then she also goes to dermatology with these rashes, which you can see is looking like a palpable purpura. So with all these things, everybody is confident that it must be Sjogren. So I asked the patient for history of dry eye and dry mouth, but direct questioning. Do you have dry eye? Do you have dry mouth? And patient says no. So there is no ophthalmic consult was sent in spite of patient having so many telltale features of Sjogren. Then on indirect questioning, which is what is our job in detecting Sjogren's, that she carries water everywhere, even in winter, and she cannot eat dry food like biscuits, etc., without getting stuck in the throat unless she takes extra water. And she puts eye drop regularly for more than 10 years. So can you see that on direct questioning, the same patient who said there is no dry eye or dry mouth has absolutely clear history, is comfortable with eye drops, so she forgot about dry eye. That doesn't bother her much. And similarly, she got used to the lifestyle that she carries water with her, and she needs extra water to have dry food, so she doesn't complain of dry mouth. So this is actually the real life story. And then if you look for carefully, you might, if you have a bias, a good specialty bias, you might see this minimal parotid swelling, which is marked here. And very carefully, if you see, there is a which is very easy to miss out and nothing, not a big sin, missing out the minimal lacrimal gland swelling here. So with this background of so many features, we do a Sherman's test, it is showing very minimal wetting, less than 5 millimeter, of course, in 5 minutes. Lip biopsy is done by throughout this thing. I have done it myself from my training till I joined Vellore, taught everyone, including interns of medicine, and that makes my job easy. And we just have to give the pathologist the procedure for histopathological grading, and you have to have a dedicated pathologist to do it. It's not at all difficult. It takes hardly 10 to 15 minutes to do a lip biopsy, which is very simple, and it doesn't have any complication. I never had any complication. We have done, I don't know how many thousands of lip biopsies over the last 25 years. So the plight of a patient of a Sjogren syndrome is so much. You can see they go from specialty to specialty. I will come to it. Even we have done a systematic analysis of how it translates to real life. I just want to mention these three people's name. They're probably some of the best teachers in life for the immediate seniors. Dr. Sunil Davargao, he was my senior in Lucknow by 2 years, and Dr. Vanchu was 1 year senior to me. He's in the US. And Dr. Maureen Rishmola, she's one of the experts in Sjogren, and I was in Adelaide for 3 years. She was one person who have stimulated further my enthusiasm to pick up more Sjogrens by giving me a lot of indirect clues. So how to suspect Sjogren syndrome in a rheumatology clinic? So any chronic inflammatory non-deforming or correctable deformity like Jacquard arthritis, you must think of Sjogren's. So unlike what you read in our books, the rheumatic fever is a cause of Jacquard's arthropathy. The more common cause of Jacquard arthropathy is lupus and Sjogren's. There's also chronic pain features is an important feature. Large number of patients of Sjogren syndrome have chronic pain features or fibromyalgia type features. Premature loss of teeth and poor oral and dental and gingival hygiene in the setting of chronic inflammatory, non-deforming or correctable deformity arthritis, you must make it a habit to look at these, and that makes things easier. And indirect inquiry about oral and ocular sicca symptoms, dry skin and dyspareunia are other features, fetal loss because I can tell you that this is a very important clue. In endocrinology is if they have a CIDP is another very important clue in our setting when you don't have any other cause. And if you have a small vessel and medium vessel vasculitis with non-deforming or correctable deforming arthritis, again think of Sjogren's. So these are small clues which the rheumatologist can easily pick up. So I'm very, as I told you, I'm very fortunate to be in this place, which has really given me so many strengths. You know, the hospital sees more than 12,000 patients every day and 2,500 inpatients every day, all specialties together, I mean. In the main campus, we have several other campuses now, 2 other big campuses have come up. And rheumatology patients alone now per year comes to about 100,000 or a little more than that per year, which is a huge new and old together, mostly old, and large cohort of most autoimmune diseases we have, including Sjogren's. I also want to mention my teacher, Dr. Mishra, Ramnath Mishra. He was my teacher in Lucknow, now he's in Bhubaneswar. And I was in 1 year as a visiting scientist in Oklahoma Medical Research Foundation, USA. OMRF is one of the, again, a great place of research in autoimmune diseases. And Dr. Hal Schofield is another big authority in Sjogren's. So I have been influenced and blessed by them. Now, excuse me, the story about Sjogren's in early days, it's not even 20 years back. There was a publication from the Lucknow, from my parent department, where I did my training, that Sjogren's is extremely rare. For so 10 years time, they only had 26 patients. And almost at the same time, the Madras Medical College, the other center where the rheumatology started, almost similar. Again, in a period of about a 4 years period, a 5 years period, they again reported a very small number of Sjogren's. So, Dr. Robert Fox is one of the experts in Sjogren's. He's sort of retired from active practice now in the US, in the West Coast. He requested us to write a chapter on his book. Myself, Dr. Mishra, and Sapan Pandya, we wrote together, and we reported that Sjogren's is rare in India. So I am equally guilty for the delay in diagnosis or awareness of Sjogren's syndrome in this country. Is it really rare in this country? After coming to Vellore, I had my eyes opened and I found it's not really rare. In 2005, in IRACON, Hyderabad, I presented 126 patients of primary Sjogren's syndrome. And immediately, as you know the culture of our professional colleagues, and as Amartya Sen rightly said, argumentative Indians, if you read his book, that we argue everywhere, from tea stalls to Facebook to everywhere. It's a good quality as long as it's healthy and positive. So the critics raised eyebrows. So the question, these must be all secondary Sjogren's. As somebody suggested, Indian rheumatoids have Sjogren, so it may be easily missed as a primary Sjogren, and many such expert comments. I did not get disheartened because I'm convinced about what I'm seeing, what I'm doing. So a journey from disbelief to reality has started. So with this background, I wanted to tell that how we proceeded further in the next 25 minutes, 20 minutes, I'll say. The primary Sjogren's is predominantly a chronic autoimmune exocrinopathy, and it's a heterogeneous disease, and its manifestations are protean, from disabling Zika symptoms to potentially severe extraglandular systemic features. Considerable immunological and clinical research of late have led to significant advances in diagnosis, prognostic assessment, and management of the disease. Primary Sjogren's, although by and large is a chronic low-grade disease with a varied presentations, and the biggest problem was there were more than 12 criteria till date. Some are too sensitive, some are too specific. Therefore, various series reported the prevalence of Sjogren's syndrome in population differently, anywhere between 0.5 to 2% of population. And therefore, mostly they were underdiagnosed, although some were overdiagnosed also in some series. So this was a comparative table where we have seen that based on community and clinic-based data, which India has clinic-based data, the highest prevalence was 0.5%, lowest can be 0.0045%. Greece was 0.6%, UK between 0.1 and 0.6, Scandinavia 0.05%, and worldwide various other series of 0.1 to 4.6%. So you can see that because of a inconsistent diagnostic or classification criteria, there was a wide variation in the this. So this inconsistent criteria and poor awareness in the past was responsible for such variation. There is also ethnic and geographic variations. We learn to recognize that PSS is a systemic disease rather than just a dry eye and dry mouth disease. And as we have seen that the direct questioning for these two symptoms, eye and mouth, will miss out most of the patients in vast majority, and currently modest estimate all over now say that approximate prevalence is 0.5% of population in most recent series with better criteria, which I'll come to. And this is almost similar to that of rheumatoid arthritis. Now, this is a very nice, elegant Chinese study, which they have compared the Sjogren's presentations between the East versus the West. So What you can see here strikingly is that the eastern hemisphere or the eastern part of the globe, we have earlier, younger age of onset, much younger, almost by 2 decades, sicker symptoms, even after objective evaluation is not 100%, where the West it is 100% up to, excuse me, and the fatigue, which is more common in the Western population, less. Raynaud's is much less in our population compared to the West, whereas organ involvement like pulmonary, renal, and autoantibodies like Rho and La or SSA and SSB are significantly higher in Eastern population than the Western. So there was no Indian data, there was no community or even a hospital data for a long time, and hospital-based data from different regions of India was attempted by IRA in 2012 before the IRACON Ahmedabad. So we were assigned from 4 parts of India, East, West, North, South, to present our Sjogren's data from hospital-based. So the objective was to retrospective cohorts from the hospital record and characterize clinical, immunological, and outcome in a quotient of patients of Sjogren syndrome. So we are very blessed to have very good electronic medical record patients, and we looked at 2004 till 2011, both outpatient, inpatient data, and screen for those days, the best criteria was AECG or American European Consensus Classification, fulfilling 4 out of 6, including 1 objective criteria. So this is the set of 6 AECG criteria. So what you can see is the ocular symptoms. You have to ask for dry eye for more than 3 months, or is it indirectly foreign body sensation or use of artificial tear for more than 3 times a day, dry mouth for more than 3 months, or is it recurrent or persistently swollen salivary glands, or patient needs liquids to swallow dry food, etc. And dry mouth, those days there was Shermer's test, and Rose Bengal was becoming unpopular, so they're recommending other tests. We had done only Shermer's those days, and histopathology with focus score or Daniel's scoring we have done, and that our pathologist, I have been able to convince them, and they were doing a good job. A focus score of 50 lymphocytes per high power field and more than 1 high power field in 4 millimeter square area. The oral signs, that is unstimulated salivary flow or the abnormal parotid psilography or abnormal scintigraphy, we never did. So we had to fulfill our criteria within this remaining 5. And autoantibodies, Rho and La, we had done. In Vellore, I had instituted every possible autoantibody you can imagine needed for a specialty. So we used to, as I showed this picture earlier, we used to do ourselves. You know, you can, the Shermer strips you can carry in your pocket, you can do in the OPD. We don't need an ophthalmologist, but we used to send to ophthalmologist just to reconfirm. And they used to do sometimes the tear film breakup time and other things those days. And the histopathology after lead biopsy, our registrars or the residents used to do. So as you know, you need to 3 out of the 4 criteria, objective criteria, the 3, 4, 5, 6, or you can have 4 out of 6 with at least 1 objective criteria, that is 4 and 6. And secondary Sjogren's also was defined in the AECG criteria, which is here. So there has to be some exclusion needed. So the exclusions, you can see all of them, including current use of anticholinergic drugs, which has been replaced now. Pre-existing lymphoma has been replaced now. I'll come to that. But hepatitis C, HIV, sarcoidosis, GVHD are present, and we'll see subsequent slide. Now, current use of anticholinergic drug has been replaced with IgG4 disease. So, AECG criteria, these are the 6 criteria. We did not do the number 5. We had remaining 5. We had to have 4 fulfilled. So you can imagine. Or you have to have the 3 objective between 3 and 6. So that's the thing. And we had to have all the exclusions, as I mentioned, and that is how we diagnosed. So can those days, after AECG, the new SICA criteria, which eventually became the ACR-EULAR, was just coming in. It was not that time ready. We are about to present that time. So can primary Sjogren's be diagnosed in absence of Zika symptoms? Some strongly suspected patients who are not fulfilling classification criteria, can they be diagnosed primary Sjogren's? Or what is the relevance of Zika symptoms in primary symptoms? Is it a big thing? Unlike all of us believe, Zika, is it the main thing in Sjogren's syndrome? So what we did is those not fulfilling the AECG criteria but strong clinical suspects. So we had that time the Zika criteria came out. 2 out of the 3 objective criteria to fulfill. That is antibody positivity, histopathology, and objective eye feature. 2 out of 3 is if it is there, even if you don't have AECG, it can be called. And we must exclude an overlap or a secondary Sjogren syndrome. And the clinical presentations, including extraglandular feature, duration of disease, immunological profile, they're all retrieved from a record. So this is the Zika criteria. Before this ACR EULAR came, this was how it started the process of the new criteria of 2016. So what happened here, you can see that apart from SSA or SSB, they had also a criteria which has been removed now. Now SSB has been removed, and positive rheumatoid factor and ANA, both are present together. ANA more than 1:320 and rheumatoid factor positive, both together in the same patient, that can be taken as a serological criteria those days. So we took that also, And histology by following the Daniel scoring, focus score of 1 and above, and objective ocular staining score. Ocular staining score has lissamine green and fluorescent dye for conjunctiva and cornea respectively. And if you have a score of 3 in each eye, then it is a Zika objective feature. As you know, the Sharmas may not be very objective. Its sensitivity is about between 40 and 50%. And you can see the exclusion criteria, 2 changes. If you compare the AECG, you can know that the anticholinergic drug has been replaced by IgG4 related disease, and the lymphoma has been replaced with amyloidosis, because lymphoma may be there as a complication of Sjogren's, so you cannot exclude it. So what was our results? So out of 423 suspected patients who were screened, we had 294 fulfilling AECG criteria. Of the 129 who did not fulfill, we had 38 more who fulfilled the Zika criteria. So altogether, we had 332 patients having clear-cut, very objectively diagnosed Sjogren's syndrome in this cohort, in this over about 8-9 years period. And you can see that the gender imbalance is so high compared to lupus and others, is almost 19:1. You can see the age is also around 44, 45, which is about decade younger than the Western population. And most people in our books, we must have read that Sjogren's is a women of menopausal age group disease, which is not true in our patient. Like you see, I showed you the Chinese people have said late 30s. We also have many patients late 30s. But what is more interesting is that the mean duration before the diagnosis, there is at least a 5-year delay. So you can see that the long delay in diagnosis. Now, what are the presenting features? You see here that because of course, a referral bias, we being a rheumatology clinic, almost 60% patients have presented with arthralgia or arthritis. All the others are between 2% and 10%. Now, what is striking here is the Zika symptoms as a patient volunteering as a feature was present only in 8% of patients. So look at this, that it doesn't mean the patient do not have Zika, but patient did not volunteer more than this. And I showed you the initial case scenario, why the patients don't complain. So it's also important. The next feature is a chronic pain, and all of us are familiar with fibromyalgia, tender and trigger points. So don't junk a fibromyalgia patient as a patient with or someone who is trying to gain something, exploiting her pain features. So we've shown you now the initial presenting feature in this slides. So you can see the distribution here. But when we objectively evaluated and followed up these patients in our hospital record wise, what is during follow-up? You can see the same patient, 8% only complained. But when you have asked indirect questions and objectively look for dry eye and dry mouth, we had almost 90% of them positive for dry and dry mouth. Sharma was also present in 90% of the patients. And you can also see that the lip biopsy was present in 95% of them suspected cases. Because ours is a skewed population. Roe and La were present in 64 and 40% respectively. ANA was present in 2/3 of patients and rheumatoid factor in 60%. So out of all this, we have among all the manifestations of different systems, we have about 1/3 of them, 121 out of 332 patients had actually major systemic features, which I'll come to that, which means major systemic means they required immunosuppressive therapy, but 2/3 of them had minor features. They did not require immunosuppression. So this is again the same thing what I showed in the preceding picture, the same thing in number and percentage involving various features of Sjogren's manifestations. So now I'll go organ-wise. So palpable purpura and a few other types of rashes were present in a good number of patients with Sjogren syndrome. And 34 out of the 332 patients, about 10% therefore had cutaneous manifestations. Respiratory, 40 patients, ILD being the commonest, but you also had obstructive airway disease features and few others. Neurological in about 32 patients, again vasculitis causing mononeuritis multiplex, symmetric polyneuropathy and other features are also present. The gastrointestinal IBS being commonest feature, which is not surprising because the fibromyalgia and IBS, there are several others who are called central sensitization disorder. They coexist. So since fibromyalgia is more common in Sjogren's, irritable bowel syndrome also was predictably more common among the gastrointestinal features. Whereas the autoimmune gastrointestinal manifestations are not so common. There are a few patients, as you can see. Hematological cytopenia was the commonest, but we had very few patients of lymphoma or malignancies. Unlike literature says 5 to 10% of Sjogren's, we had our patients are almost 5 to 8 years disease, so even maybe a longer follow-up would show more. But in our experience, the lymphoma is much lower compared to the Western population. Renal, although 14 patients did not undergo renal biopsy, but biopsy proved glomerulonephritis. Chronic interstitial nephritis, as you know, is the commonest renal pathology. And there are also a few other uncommon features, as you can see here. Renal stones are not so uncommon, again as a sequelae of chronic interstitial nephritis. And bad obstetrical outcome was present in 20 patients. Surprisingly, complete heart block was only in 2, spontaneous abortion was in 14, and even more surprisingly, of the 14 with spontaneous abortion, antiphospholipid antibody was present only in 2. Predominantly it was SSA and SSB related complication. And as I have shown, again, this is just to summarize, so that arthritis, arthralgia, followed by chronic pain features, followed by dental problem, and then the other features follow in the varying percentage of occurrence. So you are familiar with this picture called cluster analysis. This is used predominantly for genetic studies, but cluster analysis is also used for clinical data. When you have a widespread manifestations, you can do a cluster analysis statistically to see if some of the features go together and some of the other features go together. Interestingly, we found 2 main clusters. The first cluster was those who were serologically positive or Roe and La, etc. They seem to have systemic manifestations like vasculitis, etc. So that was very interesting. Whereas, so this is the one. The second bar is the one where SSA, SSB, skin, vasculitis, neurological, autoantibodies were clustered, whereas the first cluster was the minor ones with mild manifestations like chronic pain, bladder symptoms, etc., who were not having any antibody positivity so much association with that. So this was a very nice observation. We also looked at the various was there any predictors by multivariate logistic regression of systemic involvement. As you see, systemic involvement requires immunosuppression. So what we found is anti-Rho and anti-La antibody had 3.4 and 2.65 respectively of odds ratio to have systemic manifestation. On the other hand, carpal tunnel syndrome had a negative association with systemic features. Chronic pain syndrome, fibromyalgia. So the patients who had fibromyalgia, chronic pain syndrome features predominantly in Sjogren's, they seem to have a milder disease and did not have much of systemic manifestation, did not require any immunosuppression. On the other hand, those who had antibodies positive, they had a high chance of having systemic disease, require immunosuppression. I hope I'm clear. Now, we also looked at the likelihood ratio. The likelihood ratio, we found that in case of skin, renal, neurological, and vasculitic complication, thereby requiring immunosuppression, the likelihood of anti-Rho and anti-La titers of being more than 160 Ru per ml was 2 to 3 times as compared to other titers. So that's another interesting thing we found. So it shows again that the anti-Rho and anti-La, if it is a high titer, even more likely to have a stronger association with major systemic complications like vasculitis. Now, malignancies, I told you, we had a very few patients. These are the 5 patients we had, and they were not as common as in the thing, but I'm sure we can follow up patients further. Now, how did we treat these patients? So, as we can see, if you remember my initial presentation, most of our patients were having musculoskeletal manifestation. So, we treated like any inflammatory arthritis. Predominantly, we treated them with hydroxychloroquine and methotrexate in various combinations. In little milder joint symptoms, we treated with omega-3 fatty acid or fish oil. And we had not used azathioprine, MMA or cyclophosphamide unless there was a systemic feature. So therefore, steroids and immunosuppression was used. Steroids only in patient systemic complications. High dose steroids only in systemic complications, 50 patients we have used. And low dose steroid, that is very low dose, something like what we use in initial part of inflammatory arthropathy, something like 10 milligram or less than prednisolone or 12 milligram or less than deflazacort initially, and taper off was used in majority. But the high dose steroid was used only in those people where there was a systemic complications like interstitial lung disease, vasculitis, etc. were there. Now, what is the outcome? So you can see this pie charts here. The blue part shows patients improved, remain asymptomatic. The green circle shows they are improving, that is on follow-up during the data recording we have recorded, they were still improving in subsequent visits, and the purple one is the worsening one, the red one is the persistent disease. What you can see is very dramatically that the joints symptoms had almost 80% had improved significantly, and in terms of Sika features, etc. Sika features, you can see that if you combine the blue and the green, that is improving and asymptomatic, again altogether they're about 70%. So 70% had either continued to improve or already asymptomatic. So what it shows that unlike what is told in the Western literature, actually speaking, in our setting where predominantly musculoskeletal because of maybe referral bias, but even in the Western literature now they show that about 60% have musculoskeletal symptoms. So they seem to do well with simple treatment like hydroxychloroquine, methotrexate in combination or alone. Excuse me. And those with systemic features, of course, we have given immunosuppression and they have done much better. In fact, almost 98% did very well. Now, when you compare our series with the other series, we had a series from Finland, Spain. We had 1,000 patient data from 10 centers, 10 centers, and we had French series from 2 centers of 445, Swedish 205, Chinese 573. They are the only one who beat us in number. And our study in a single center, the second largest number of patients. We had seen that our patients had higher Rho and La, as we've shown, lesser cryoglobulinemia. We had more female predominance, and we had very less Raynaud's phenomenon. We also had lesser hyperglobulinemia. So these are the features when you compare. We published, reviewers said that this is not good, this is not this. So we had finally got, and once we got it published, we had a invitation from the
Sir, you've got muted, sir. Sir, you've got muted.
So, what I was saying is that after we published our series, was it audible that time?
No, I think just what the letter which you got from there, you can start.
Yeah. Okay. So,
yeah, from here.
From there, yes, from there we had joined, and we found that our female to male predominance and the lower prevalence of Zika symptoms in Asians were vindicated, and this was published in Annals of Rheumatic Diseases in 2017. And then we also did a very interesting study where we looked at the determinants of diagnosis and disease course in primary Sjogren syndrome, and we did a results from data mining of electronic health records. So what I want to say here that we again looked at the data mining, how patients went into surgery. You can see all specialties. You can see rheumatology followed by internal medicine was the major specialties where they went. Also some went dermatology, hematology, etc. And you can also see that the distribution of the presenting complaint, the first consultation, again musculoskeletal, followed by neurology and other skin and autoimmune manifestations diagnosed elsewhere, etc. Zika was very little. And we did a heat mapping. And what it shows is that the first visit, Sjogren's was suspected in 83 of them, followed by medicine in 19 of them, all the others in a smaller number of patients. And what I want to draw your attention here is what in the data mining analysis showed, interestingly, is that if your first impression was a primary Sjogren syndrome, the logistic regression shows there's a significant higher probability of diagnosing Sjogren syndrome. If you have further inquired, asked about Zika symptom, again, the logistic regression shows independent predictability of a correct diagnosis of Sjogren syndrome. And if you have ordered SSA antibody, again, the predictability of Sjogren syndrome was very high. So this is in multivariate. Univariate, there are of course many features were significant. So these three features, the first impression based on your patient's presentation and your awareness, you suspected correctly Sjogren syndrome, or you have inquired about objectively about Zika symptoms and asked the right questions, indirect questions for Zika symptoms rather than direct question, and if you have done the objective evaluation, and if you have ordered the assessment, this background, these three are independent predictors of a correct diagnosis of Sjogren syndrome. I hope I made myself clear. Now, so this is again the 24 different departments at first visit of majority board. Again, you see the spontaneous Zika presentation was present only in 12% of patients, and the provisional diagnosis of Sjogren syndrome was there in less than 50% of the patients in these all specialties across patient has gone to. And you can see even rheumatologists had correctly suspected Sjogren's only in 64% of the patients. So it is, you can imagine that why they are missed out so easily. And uh, there have been other series, we have reported ours. The big data group also have reported that the Asians have lesser Zika symptoms. There's also a prospective study from Chennai. They have also shown that only 40% patients did not complain of Zika at all, even after asking. So this is the story of why Zika is less common. There are possibly 4 mechanisms. One is the perception about the illness, because probably people find it less troublesome because they take the remedy by taking water or putting eye drops. Hormonal, as our patients are younger, probably the hormonal role may be another factor which may influence the Zika features. The wording of questions, as you have seen, the direct questioning always draws a blank. And the occult primary Sjogren syndrome, extra glandular features may precede the diagnosis of Zika symptoms, as I have shown you in our patients, like joints, etc. Now, Zika cohort also showed dry eye, dry nose symptoms, did not show a significant association with presence of lymphocytic infiltration, SSA or SSB antibody positivity, or ocular sign. So what I'm trying to, it shows that we should not attach too much importance to Zika symptom. So again, this heat map was done in this Sjogren's big data group. You can see that major systemic features like hematological, vasculitic, cutaneous, biological, they correlated the best with the immunological parameters, whereas the articular, muscular, they have had a lesser correlation. The red ones means very high significance, and the pink ones are less significant than the red ones. And this also showed that what is interesting, the European Sjogren syndrome disease activity classification, that there are 12 sets of suspecting features in the broad category. There is probably much more to that. There are many features which are not covered under the ESS DAI inclusion features. So this is the NEJM picture. It shows again the articular in that author's experience in various other series in the Western population, about 40%. But you can see all the others are much less, 8, 9, 10% prevalence. Glandular is about 20% presentation. So you can see here also shows the glandular presentation may be only about 20%. Now, ESS DAI core features are here. These are 12 sets of criteria. But what happens is there are something outside the core features which are not usually, sinusitis, interstitial cystitis to episcleritis and acute pancreatitis. There are many other features, Raynaud's, which are not part of the ESSDI. They may also have association. So they have looked at that, the ESSDI features and SSA SSB antibody correlation. So between 60 and 80% of the SSA and SSB correlate with the ESS DAI features from pulmonary, valvular, pericarditis. These are features which are normally not considered in the core features. So basically, I'm not reading this whole slide, but what I am trying to show that organ-specific clinical syndromes that may alert to a possible underlying Sjogren syndrome can be so many. You can see neurological, there are so many, pulmonological, nephrology, obstetrics, ENT, pediatrics, dermatology, urology, cardiovascular. So unless we keep all this in mind, it's easy to miss out Sjogren's. It's like that, as visually, suppose somebody visually handicapped and trying to feel an individual part of an elephant, and you will describe it according to which part you feel. As a holistic approach to the diagnosis of Sjogren's need a good overview of all the manifestations, because it is not just a disease of dryness, it is a complex and heterogeneous disease. It's a systemic autoimmune disease characterized by B cell activation predominantly. Lymphocytic infiltration of exocrine glands is not same as dryness, as I have shown you that the big data showed that the SICA did not correlate, and anti-Rho positivity is possibly important. Now, as I told, the little comparison about the AECG criteria and the ACR EULAR criteria, which came out in 2016. What we can see now is most of our rheumatology criteria is now becoming objectively scored with numbers. So we can see that highest score is given for histology and Rho antibody. And for ocular dryness, Sharmas, and unstimulated salivary, only score of 1. So you need to have only score of 4 to diagnose Sjogren syndrome. And in the background of one of the ESS-DAI domain features. This will be definitely further expanded. As I have told you, ESS-DAI 12 domains features which are described classically as a mandatory clue may not be fully inclusive. This needs further expansion. But what you can see here, that somebody having just a histology and antibody do not need any other criteria. So you can objectively, it's like now lupus, you can diagnose by ANA positivity in high titer and a kidney biopsy showing lupus nephritis. You don't need any other feature except the inclusive or suggestive clinical symptoms. So ACR EULAR criteria has, like many of the newer criteria, has made it very objective, and you can see these numbers. It's all about numbers now. People want to be very objective. So this is again the same thing. Is you can see that we, even if you don't have any of this, okay. So I'm sorry about this slide. This is about the ESS-DI features, which needs further expansion. And the Rose Bengal stain has gone out of fashion because it causes a lot of complications, irritation in the eyes. So ocular staining score, there are two components, Lissamine green for the conjunctiva, and you have fluorescent dye for the cornea. And this is how it is scored in each eye, as you can see. Very interesting. You have actually, you have a score of 0 to 3 on either side, for Lissamine green, and fluorescent for the cornea. And this is for the number of dots you get by staining. And you get additional points if there is a patches of confluence, staining in the pupillar area, or one or more filaments. So theoretically, this is 3 plus 3 plus 3 plus this 3. So only maximum 12 score is possible. If you have any one eye 3 or above, it fulfills the objective classification, objective criteria for dry eye. So this is very important. Ophthalmologists in our country are very reluctant to do it. So I saw, the OMRF, the Sjogren's research clinic, they used to have the strips where it just takes a few minutes to do the corneal and few minutes for the conjunctiva using the strip, which does the staining and quickly count it. This thing, it doesn't take more than 15 minutes per patient. But in our country, even in Vellore, I am finding it very difficult to convince the ophthalmologist to do it because they're busy OPD, they don't want to do it. Unfortunately, but it should be done. But fortunately, because the objective criteria has got a better score, we can manage without it. Now, this is normal salivary gland on the left side. This is a Sjogren's features, and this is a germinal center. C is a germinal center formation, which shows a very, very advanced Sjogren's histology. Now, as I have shown you that you should have at least one of the ocular oral dryness symptom. With that, if you have objective ocular or oral, you need to have either Rho antibody positivity or a biopsy positivity. Or if you have one of the ESS-DI domain features, even there is no SICA symptom, any other ESS-DI domain feature, you need not even have objective dry eye or dry mouth. That means totally in absence of dry eye and dry mouth, subjective and objective, with just one ESS-DI domain feature. If you have both Rho and La positive, both Rho and histology positive, then you diagnose Sjogren syndrome. So you can see that the journey has become, it has come to more objective features now, and it is now much more objective than before. Uh, uh, Sorry. So you do not have to have very complicated procedure now. We need to have objective features now. That's more important. So a differential, again, sorry about the slide. There is whole lot of differentials are there, but if you see the exclusions, which I have shown in 2 slides, the exclusion needed like sarcoidosis, IgG4 disease, lymphoma, amyloidosis, hepatitis C, HIV. These are the important exclusions for Sjogren syndrome. So CT of parotid gland can show sometimes changes of not only the glands or annullars, but sometimes can be punctate calcifications. The ultrasound is much better. On the A is the normal, B is Sjogren's features, which shows the hypoechoic rounded areas marked by arrow, and it corresponds very well with histology. We have also had an MRI also shows very important. The A shows that diffusely throughout parotid glands have multiple punctate areas, and you can also see T2 is much more high signal intensity in the Sjogren's parotid glands. So again, this is a normal histology, normal ducts. This is the lymphocytic infiltrate of focus score 1 and above, and this is germinal center formation. So to diagnose Sjogren syndrome early, please remember patients will never volunteer Sjogren syndrome, and there may be even negative response even on inquiry. The second is Sjogren syndrome can often be misdiagnosed as RA or lupus. Remember that the arthritis is usually correctable deformity, and Sika features may not be obvious even on inquiry. And if predominant features present, lupus, systemic vasculitis, of course, you need to rule out. But what I'm trying to say, all ANA positives are not lupus, all rheumatoid positives are not rheumatoid arthritis. Therefore, you may also have Sjogren's to be kept in mind. And telltale features like poor dental hygiene, long-standing non-deforming arthritis, and important exclusion like hepatitis C, sarcoid, and IgG4 disease can help in this process. So in India, our Sjogren's is a much younger age of onset. The commonest initial presentation include musculoskeletal pain, including arthropathies. Sika is rarely the presenting feature, though it may be present in majority, they don't volunteer. Varied presentations and hence delayed diagnosis, as I've told, because the inconsistent criteria in the past, low prevalence of Raynaud's, cryoglobulinemia, and hyperglobulinemia in our patients. Seropositivity has a good association with major systemic features, and milder forms are usually seronegative, as I have showed you in the cluster analysis. And most patients do well with hydroxychloroquine and methotrexate. Now, a few recent data just takes 3-4 minutes. So these are based on the various studies. They have found that now there are various other the topical applications are being used in Sjogren syndrome, and there is a lot of agreement on using topical applications there, but there is no, even though it is being propagated by many, we actually do not use too much of this cevimeline or other agents because they have a lot of those cholinergic side effects and diarrhea, vomiting, etc. But these are some interesting data. This was a patch trial which showed that the hydroxychloroquine can significantly prevent complete heart block in mothers, who had earlier fetal heart block and fetal loss. And another study, both in vitro and in a clinical trial, showed that leflunomide combination with hydroxychloroquine significantly have an additive effect in immunological and the clinical features, including the ESS, DII score. And sequential use of sequential use of belimumab and rituximab actually reduces salivary gland resident B cell population. The clinical implication is is not that much significantly found, but they seem to be having immunological impact. And then future, the precision medicine is coming up. There are several trials have been conducted on newer biologics, etc. And combination of various cytokine profile may predict the treatment response, to, especially to simpler agents like hydroxychloroquine and leflunomide. So with this, I am concluding. We have had a very good number of publications using the European, the global Sjogren's Big Data Group collaboration. This is Vellore Fort, which is about 8th century fort, and very beautiful. And this is Golden Temple in Vellore. 2,500 kilogram gold laid over stone structures, beautiful, magnificent, world's biggest golden temple. In fact, many of you may not know. This is the college chapel in the college campus where I live. We have many campuses. And you know why I put this picture. Most of you may be knowing she has Sjogren syndrome. So thank you very much. I'll be happy to respond to any questions if you have.
Thank you, sir. It was a fantastic talk. So there are some questions in the chat box. So, but I'll just ask one question before that.
Yes.
So there's some lupus patients also who are SSA, SSB positive and Sjogren's. So is there a difference in the fetal risk between Sjogren's syndrome and compared to lupus with these antibodies positive?
Very good question. In fact, absolutely no difference. SSA, SSB positivity, whether it's the setting of lupus or Sjogren, has the same risk of fetal heart block. The first time the risk is about 2%, but as you know, the subsequent pregnancies, once it has happened, the subsequent pregnancy loss risk is 10% and above. So I think the risk is similar, and we have had lupus patients also having similar complications. But because we use every lupus hydroxychloroquine and every Sjogren's hydroxychloroquine, maybe we see it much less. As you have seen in our series, we have only had 2 patients out of 332 who had this. So thank you for this nice question.
Dr. Sandeep, Dr. Varsha, you can maybe take the questions in the chat box. They are our faculty at the department. Yeah.
Sir,
Good evening, sir.
Yeah, good evening, sir. So wonderful lecture, sir. Sir, I want to know how is your experience with the unstimulated salivary gland flow, because I haven't seen many people practicing that, even though said to be very well.
Truly speaking, we don't do it. The reason being, first of all, you can see that the objective salivary flow score is only 1. And even before that also, we never did it because in a busy OPD, it's a little messy and it needs additional, space, people to do that. It's actually speaking not that difficult. It's just probably a psychological barrier. When I was in Oklahoma for a year in Sjogren's research clinic, we used to see they used to do it as a system. One nurse used to do it. Just patient have to hold their tongue and in a test tube and collect the saliva. And once it is 1.5 millimeter, 5 ml or more, they used to stop if it is less than 15 minutes time. So it can be done. But what I am trying to say that even without this, we could diagnose most of them. And if you include this, I do not know how much you will miss out. And all the scintigraphy, etc., they require nuclear scan, so which require BRC license and handling of radioactive isotopes. So we have stopped doing it now. Ultrasound, we have done a study, similar correlation we found, ultrasound and parotid ultrasound and the lip biopsy correlation. We are in the process of publishing it. So it is probably coming up. So yes. So
good evening, sir.
We have not been doing. Hello. Yeah, we have not been doing unstimulated saliva. Oh, sorry. Am I audible?
Yes,
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 sir.
you're
Okay.
audible, sir.
Okay. Thank you.
Good evening, sir.
Good evening.
Very lucid talk, very enlightening, and you have laid emphasis on everything in Sjogren is not Sikka, and
Yes.
we may miss many Sjogren if we just
Yes.
keep our eyes only on the Sikka. So
Yes.
I just wanted to know, sir, before I take some questions in the chat box, how many actually occult extraglandular Sjogren you found in your experience, as in whatever objective tests we do
Yeah.
for ocular and oral,
Yes.
doing
So
everything and then ruling out.
yeah. So if I go back to my slides, you can see that majority of our patients are presented with musculoskeletal symptoms. All the others were much less. So that itself shows that the extraglandular features were the predominant features. And now even the big data presentation shows that the extraglandular, especially musculoskeletal features. So this, if you can see. So this is the presenting feature in the first time. So you can see that 60% actually have joint symptoms and about 6% chronic pain features. And this is almost all over the world now, the similar presentation. And although I said 8% of patients who complained of Sikka, they actually had Sikka, which we found on objective evaluation and further questioning. But if you see the patient's presentation, we actually went by all the extraglandular features. As I've told you, if you have a RTA in your hospital, renal tubular acidosis present, periodic paralysis patient, I can tell you 90% chance it will turn out to be Sjogren syndrome. If you get your CIDP referred to you by neurologist for some reason, someone might have done on ANA or RF, you see it, very high chance, if there is no other obvious cause for CIDP, it will turn out to be Sjogren syndrome. So actually speaking, I think the predominant presentations are extraglandular. The glandular features are there, but somehow, as I've told you, the patients are not that much worried about it because they find a solution to that by artificial tear, and they forget to tell dry eye because they're happy with the artificial tear. So I think extraglandular is the way to move forward. Remember when I first in Hyderabad, Bhaskar Das told me, in meeting Debashish, you look for CIDP patient. When I went to Australia, Dr. Maureen told me that please try looking for chronic pain features, fibromyalgia features. Every fibromyalgia that comes to your clinic, don't just junk them as some kind of useless patient in your clinic. So that is one. And what I learned is that if you have a chronic inflammatory polyarthritis with correctable deformity or non-deforming for many years, make it a habit to look at the mouth. If they have poor oral hygiene, not only poor oral hygiene, they have lot of teeth are bad. I have had several patients who had the teeth are almost half gone or completely toothless, 35, 40. And there is no good explanation for it in spite of whatever poor oral hygiene we have. So I think these are the two things. So you have to combining, your suspicion should rise in a rheumatology clinic, anybody who looks like rheumatoid, not behaving as bad as rheumatoid, and don't make it a habit to look at his oral cavity. And if you have a Sharma strip in your pocket, just do it, even if he doesn't complain of Sharma test. So I think these are other ways. Once you start there, you pull the ear, the whole head comes towards you. So that way, I think we can.
Thank you, sir. So there are few more questions in the chat box.
Yes.
Dr. Gill is asking, sir, have you seen cases only with lacrimal gland involvement?
Actually speaking, uh, very few. If you see our series, very few actually had the lacrimal gland alone as presentation. Uh, so we parotid and lacrimal gland enlargement were there, but they were not the primary presentation of the presenting feature. As you can see, even parotidomegaly was present only in less than 30 patients out of 332, so less than 10%. We have had a few patients, but I must warn you one thing. If you get a big lacrimal gland swelling, we find nowadays IgG4 disease is
IgG4.
more likely cause than Sjogren syndrome. And if you get a big parotid enlargement, turns out to be Sjogren, very high chance of lymphoma. Almost all our lymphomas, I told you 5 cases of lymphomas we had out of this series, and all of them had big parotid enlargement. So a late Sjogren's with big parotids is a big clue for lymphoma in the setting of Sjogren's. The other
So yeah,
clues are persistently low. Yes, please. Go ahead, ma'am.
that's what I was
Yes,
asking.
please.
Are there any other risk factors for developing lymphoma in Sjogren's?
Yeah.
And how
So that
frequently should you look for them?
yes. So two features are very important. If you have a persistently low WBC count, not responding to anything. Number two, persistently low C4 complement. Persistently low C4 complement, a persistently low WBC count are two important clues for developing lymphoma in the setting of Sjogren syndrome. Actually speaking, we have had those patients. One of them, lymphoma, is one of the
So we can't hear you. So
am I audible now?
now, yes, sir. We
Yes.
missed the
Okay.
last couple of
So what
minutes.
I'm
Yes,
trying to say that we have, as I told you, out of these 5 lymphomas we had, one of them was a professor here who retired, much more senior to me, and she has been living with Sjogren's related lymphoma almost more than 30 years now, or 27 years now. From the time I joined Vellore 27 years back, yeah. So it was diagnosed that time, and she had chemotherapy, and she did well, and she's in remission. Absolutely nothing now. She's all right. So it's our Sjogren story, lymphoma story in Sjogren's is not that bad as it is described in the Western literature. Maybe, I do not know. We have to look at the other point is, which I did not do a study, which I wanted to do. Maybe one of you can do it. From the hematology angle, if we try to look at all the B-cell lymphomas setting from hematology, looking back for Sjogren's may be a good idea. Like I said, looking back from CIDP, looking back from dental problems, looking back from non-deforming arthritis, looking back from fibromyalgia, how we picked up Sjogren's. I think looking back, retrospective evaluation in the setting of lymphoma or hematology patients may not be a bad idea to look for that. Then we may get a little higher incidence, I presume, because Sjogren's being a low-grade, mild chronic disease with a protein manifestations may not have bothered, they might not have been bothered much by the Sicca symptoms unless they had vasculitis or ILD or something. And they might have straight away gone with a lymphoma to a hematologist. So that's also possible. So I think looking back from other extra glandular or extra Sicca symptoms or complications may be a good idea to look for this complication.
Yeah. Thank you, sir. The next question is by Dr. Parul. Is it possible to have all the telltale signs of Sjogren's and yet be negative for both anti-Rho and La? This being said, all other exclusions have been made.
Yes, it's possible, very much possible. As I've shown you, the prevalence of Rho is about 60%. And you know that the raw ELISA kits are predominantly based on bovine raw antigen coating, and somehow the sensitivity has not been very high. So you can have, therefore, we have many of them. As I told you, about 30. We also had about 2/3 of them only raw positive. So we had Sjogren's who had objective Sitka, and we had a lip biopsy positive, and they had Sjogren's. So yes, it is very much possible without autoantibody still to have Sjogren's syndrome, because you need a score of 4. So if you have a histology, you get a score of 3, and any one of the other, including the objective Sitka, you get a score of 1. So you can get a score of 4 without the antibody also.
Sandeep, you'll see the next question.
So, yes. So the next question is, please elaborate the role of omega-3 fatty acids in Sjogren syndrome.
Very nice, Sandeep. Actually speaking, omega-3 fatty acid is very dear to my heart, because my influence of my work in Adelaide for 3 years, my boss there had a lipid lab. This is the only rheumatology department where there was a lipid lab. There was an excellent scientist who used to work on omega-3 fatty acid in early rheumatoid arthritis. Actually, that was the only place we have seen how they had worked out the anti-inflammatory dose of omega-3 fatty acid. So I must tell you about one thing here to everybody's knowledge, that omega-3 fatty acid, that is N3 fatty acid, having an anti-inflammatory dose is much higher than how people give like a ritual 1 or 2 capsules of Maxipa or omega-3. It does nothing. The 6 to 8 gram per day of omega-3 fatty acid, that is eicosapentaenoic pantanoic acid and docosahexaenoic hexanoic acid together, 6 to 8 gram per day, which comes from 6 to 8 gram requires about between 18 to 20 capsules a day. Now, if you have to take 18 to 20 capsules a day, it is very difficult to take it together, because there'll be belching, gastritis, fishy smell coming out in belching. So the way to take it is, I have had a few psoriatics, few rheumatoids who are very resistant, so-called nature restricted people who do not want any treatment, that kind of people. And I have managed them for more than 20 years with that. So what I learned from there is it has to be taken sandwiched in fruit juice. So you take 10 ml of fruit juice, 2 capsules or 3 capsules each time, and 10 ml of fruit juice again. If you take that way, somehow it settles down in the stomach and doesn't have a belching and reflux symptoms. You should never give cod liver oil as a substitute for omega-3 fatty acid, because in that dose of cod liver oil, there is going to be vitamin A and D toxicity. So we need a pure omega-3 fatty acid. So that is one thing very important. Some patients who love to have only natural therapy do not want, and they don't mind fish oil with their vegetarian background or something. It can be tried in a milder inflammatory disease. There have been also trials now. We have done in vitro studies here. There have been trials in Sjogren's, osteoarthritis, and even early rheumatoid in Adelaide lab they have done. And there have been an additive benefit to existing therapy by adding omega-3 fatty acid. So that is one thing. I also want to mention here on very good thing about many patients in India, love to have a dialogue with the doctor on diet, So I must tell you that this is not completely unfounded. We should not ignore it completely. I have been involved with some work with omega-3 fatty acid and curcumin, and historically India was invited by for gold or diamond, but they were invited for spices. So spices are strength, and if you do a PubMed search, you'll find plenty of literature supporting evidence supporting almost all the Indian spices of anti-inflammatory action. Coming back to fish oil or omega-3, suppose someone is vegetarian, and what are the cooking oil which should be used for omega-3 fatty acid? Our Indian cooking is not the right way of eating olive oil, because we heat up the oil, and if you boil olive oil for too long, it loses all the omega-3 fatty acid activity. So they put it on the salads and all that on the raw, and that is not our usual habit, although maybe the upper middle class and the highly sophisticated class, they take it. But among the Indian cooking oil, actually speaking, mustard oil is one of the very good ones, having very high omega-3 fatty acid. And do you know which cooking oil in India is the worst for omega-3 fatty acid? Actually increases the risk of heart attack. Is sunflower oil. It has more omega-6 fatty acid than omega-3 fatty acid. So you can, if some people are trying to change their healthy food habit from mustard oil into sunflower oil, you must discourage that. If someone is taking fish, if somebody takes a 5 to 6 fish meal a week, they don't require additional omega-3 fatty acid. That provides a significant amount of omega-3 fatty acid. So omega-3 fatty acid, there are smaller trials, there are in vitro studies, there are small clinical trials, osteoarthritis, Sjogren's, and early rheumatoid arthritis, having a modest benefit. I wouldn't say that should be the only treatment option, but we have used for some people where the symptoms are very minimal, and we have done some in vitro studies also. It is showing a significant influence on using the supernatant of the cells from the live biopsy tissue, that they suppress the pro-inflammatory cytokines also in vitro. So it's not the first line of treatment, but when there are some patients who are not keen to take any treatment, they will always complain of side effect to everything, and they would like to have something natural, and they don't mind taking fish oil. I think it's not a bad idea for some people, but please don't take it as the first line of treatment for everybody.
Thank you, sir. The next question is, what is your management approach in Sjogren patients with recurrent parotitis? Only steroids or steroids with methotrexate or azathioprine?
Yeah, recurrent parotitis is probably most seen in pediatric Sjogren's. This is a very small percentage. Chronic recurrent parotitis, is an entity which is more in pediatric Sjogren's, but yes, we have also a few adult Sjogren's with that. It's not a very common thing, and then there could be other causes for it also. It need not be always Sjogren's also. It may be an infective cause. It may be a feature of sometimes IgG4 disease also. So yes, steroids is one of the ways of managing it, and a second line agent, if it is a really chronic, persistent, chronically recurrent problem to the patient, then I would also, because you can't keep on giving steroids, you taper, again it comes back, again you give steroids, so even eventually end up giving. So one is, I have not had this problem so much in real life scenario. I have given for such people, I think, if I remember, maybe one patient in adults, that much a problem. We gave mycophenolate in maintenance, and I think it was quite okay. But what I'm trying to say that recurrent parotitis need not be always Sjogren's also. It could be other causes. It could be an antibody by itself. It can be IgG4 disease. It may be also a harbinger of lymphoma. So it may be sometimes an infective etiology also. So it's not always the first. Sjogren's is always not the proven case of Sjogren. You have recurrent parotitis, then of course you do give, and keep a close watch on development of lymphoma.
Yes, sir. Thank you, sir. Treatment of dysautonomic symptoms and small fiber neuropathy symptoms associated with Sjogren's.
Very, very good question. It is probably one of the most difficult challenge to treat dysautonomia and Sjogren's. Actually speaking, everything Sjogren's is not because of immunological process. People still think that many, especially Sika symptoms, as I've shown you, the big data also shown that many Sika symptoms are not linked to immunological problem. So the autonomic dysfunction could also be controlling the production of saliva and tears significantly. And dysautonomia may not be a direct sequelae of inflammation. It may be another associated complication of Sjogren, and it is there is no single or a clear answer to that. So as of now, we only know how to treat it symptomatically, as well as how to treat when there is a significant inflammation. Dysautonomia is a big challenge, and actually speaking, as of today, there is not a great deal of advancement to treat this satisfactorily. On the other hand, you said about what is the other one? Dysautonomia and
small fiber neuropathy.
Yeah, small fiber neuropathy. Now people have started treating like a. They say the small fiber neuropathy should be treated as you treat vasculitic neuropathy. So small fiber neuropathy people have treated with rituximab, with the steroid plus second line agent, with satisfactory response. I remember in one of the EULAs about 10 years back, small fiber neuropathy was first time presented that this is a major problem in a small percentage of Sjogren's syndrome patients.
So we can't hear you, sir.
Is it clear now? Now, is it okay?
We just missed the last one or two sentences. Yeah.
Oh, I said that small fiber neuropathy is now treated more like a systemic complication. And rituximab. First came, I saw in EULAR one of the very impressive talk in EULAR by I forgot one of the European groups, that this has not to be ignored, and it was actually earlier ignored or undetected, and now people treat it like a systemic complication, like any other systemic complication with immune suppression.
Any more questions are there, Dr. Sandeep?
Yes.
Just see.
Yes, last question from the audience we will take. So what is the impact of Rho52 antibody, either alone or in combination with other antibodies, on phenotype of Sjogren's syndrome?
Yeah, surprisingly, they have removed Rho52 from the classification criteria. You have SSA both Rho60 and Rho52. Rho52 actually has a good association with complete heart block, as well as apoptosis of the cells in the AV node and in the conduction tissue, as well as risk of lymphoma. So Rho52 actually has significant association with lymphoma and heart block, and I would probably give a lot of importance to Rho52. Because the prevalence, the criteria, they would like to have very sensitive features, because Rho52 is not so common. Therefore, probably they have excluded it in the criteria. Same is La or Rho SSB was also very specific in the Sjogren's, but they have removed because the prevalence is about 25-30%. What I'm trying to say, Rho52 is, if it is found, if it is tested, I think it has significant importance in major systemic complications, including.
Yeah, I think there's one more question here. Does a persistently high ESR or elevated globulins in the absence of extraglandular symptoms warrant a systemic therapy in Sjogren's?
Yeah, I'm surprisingly, we did not find a very high percentage of hyperglobulinemia in our population. I don't know why. Uh, mm, but about ESR, in our country, ESR is probably one of the least valued. I don't value it much in our population. The reason being, almost 90% of women have hemoglobin less than 10, even well-fed, well-nourished from upper strata. The one of the commonest cause of high ESR is low hemoglobin. Number two, there's so much of intercurrent infection in the community. And ESR depends on fibrinogen, which is a long half-life. And once you have an inflammation of any etiology, including infection, the fibrinogen produced will not go away. That means even after control of inflammation, ESR continues to be high for some time. On the other hand, even when inflammation starts, ESR will not rise for some time because it takes some time for the liver to produce fibrinogen. So ESR is, for these reasons, because of high anemia in the community, because of its longer half-life of fibrinogen, because of delayed production of fibrinogen in response to inflammation and infection, because of widespread community infection, ESR is not the best of the markers for Sjogren syndrome, I would say. But yes, hyperglobulinemia, I would have expected it to be higher. So you can look at your Sjogren's patients. Surprisingly, I did not find that much. But what happens if you find high globulin in patients with Sjogren's syndrome? So one of the things which we should look forward in follow-up is a monoclonal gammopathy development. So because all the autoimmune diseases are diseases of oligoclonal expansion. And in the setting of oligoclonal expansion, the chance of monoclonality in future is not that uncommon. It is not that rare, though it may be uncommon. So therefore, you do get a lupus and Sjogren or rheumatoid having lymphomas. So I think, yes, if you have a high globulin, there are many causes. It's like an acute phase reactant. So globulins will be high as an acute phase reactant. So, but if it is a persistently globulins are high, no other cause, I think if it's a persistent for many years, even after disease under quiescent phase, maybe not harmful once in a while in 5 years or 10 years. I don't know whether you should check serum electrophoresis for an M band. So that way. So I think yes, you have to go by case scenario. I don't think I can tell a general rule for every case of hyperglobulinemia. You should not do electrophoresis. I cannot say that, but maybe you have to judge it yourself on case by case. Yes, the first thing is it's an acute phase reactant. Between the two, ESR and hyperglobulinemia, I think ESR is a much worse acute phase reactant. CRP is probably better than ESR. Thank you.
Any more questions, Dr. Varsha, Dr. Sandeep, or anybody in the audience is free to ask? Yeah. So thank you so much, sir. We had a very, very interesting talk and a very active discussion. We are really obliged to you for joining us today. We hope to keep the interaction ongoing. Thank you so much.
Thank you so much, sir.
Thank you so much.
Thank you, everyone. Thank you for giving me this opportunity. Thank you.
Thank you, sir. Good night, sir. So we
Good night.
the meeting close. Bye-bye, sir. Good night.
Bye.
Good night.
Good night.
Good night.